My presentation today will be about the evaluation of the right ventricular function. Evaluation of the right ventricular function by transesophageal echocardiography. When you see this video clip of the LV, I think you can diagnose it easily in few seconds, and you can reach the diagnosis. You can detect that the LV is markedly enlarged, there is global hypokinesia, and ejection fraction, even without calculation, is less than 20. Very easy and all accustomed to evaluate the LV. Whether you see it by the transthoracic or transesophageal, you can appreciate that the LV is markedly dilated with marked reduction of LV systolic function. But what about the RV? We don't have yet a solid criteria to evaluate the RV function. We started to face really this problem after introduction of the LVAD program in our center, and every time the surgeon asks us what is the RV function, because it is one of the most important determinant factor for prognosis. If you read a book like Weigenbaum, a famous textbook of echocardiography, you will find 100 pages talking about the LV function, how to evaluate, how to estimate, and the different methods of calculation of the LV function, and it become everyday practice with well known to all of us. But if you want to read about the RV function in any textbook of echocardiography, you will find only few pages. So they call the RV the forgotten chamber. Forgotten chamber. A little is talking about it. But why? Why it is called like this? It is a specialized chamber with different morphology, different anatomy, different physiology, and different function. As regards the anatomy, it has triangular in shape in the coronal section and crescent shape in the transverse plane, which make assessment technically more difficult compared of the circular or ellipsoid shape of the LV. Here, the complex anatomy of the RV and marked trabeculation inside. 3 papillary muscle, more trabeculation, modulator band, etc., which making delineation of the endocardium is more difficult compared with the LV. Anatomically, it is divided into inlet trabeculated apical myocardium and infundibulum. The thin endocardium consisted of a superficial and deep layer. The superficial layer extends to the LV, and the deep longitudinal layer play a key role in the global RV contraction. And this is a big difference between the RV anatomy and LV anatomy. In contrast to the LV, the RV lack a third layer of oblique fiber, thus contraction is mainly from base to the apex, not rotation like the LV. Normally, the RV work as a high volume, low pressure pump in contrast to the LV. Its performance is affected by contraction of predominantly longitudinal fibers, as well as afterload and preload. And that is why we depend mainly on this understanding of the physiology and longitudinal motion of the RV rather than the circumferential motion. Nowadays, there is no doubt that the RV play a critical role in the management of different cardiovascular disease. Indeed, the function of the RV is a strong determinant of prognosis for patients with congestive heart failure, ischemic heart disease, patients with cardiomyopathy, and congenital heart disease. Therefore, there is a great need to assess its function accurately. So, this is our gold standard or everyday work in assessment of the right ventricle. Estimation of the right ventricular contractility by echo is a challenging task due to its unique anatomy, physiology, many indices which have been described as a surrogate parameter of the RV global systolic function. According to the current guidelines for chamber quantification, sonographer should use multiple acoustic windows to view the right heart from the different perspectives. Moreover, there is a strong need to measure various parameters since single index of contractility is never enough. So, this is the view we usually use in determination of the RV function. Apical mid-esophageal for a chamber view. You can see the RV accurately and observe the size of the RV in comparison to the LV. Usually the RV represents 2/3 the size of the LV. If it is equal to the LV, it is enlarged. If it exceeds the size of the LV, it is severely or markedly enlarged. Another important view which helps us to guide the RV function is the RV inflow-outflow tract view. You can observe the RV contractility nicely in this view also. In transgastric view, you should take this view at least to see the interventricular septum, which share a part in the function of both RV and LV. Then go more deep to see more apical part of the RV and the septum and the dependence work of the septum in relation to both ventricles. Here you can appreciate how much trabeculation within the RV at the site of the apex. Again, this make measurement of plain systolic excursion or TAPSE, Doppler tissue imaging, Doppler-derived tricuspid lateral annular systolic velocity, S prime wave, RV index of myocardial performance, fractional area change, and novel technique like 3D and strain evaluation of the RV. Here, we start by linear measurement. You can measure 3 which represent the RV function. Normal RV function from 32 to 60, mildly impaired if it reaches to 25, and severely impaired if it is reaches than 70. The number is much less